Okay, hello. I believe we're live. So this is the newborn life support session, and I hope that we provide you with what you are expecting to hear on newborn life support. My name's John Madar. I'm privileged to be the education chair of the NLS subcommittee, and I'm joined by some of my colleagues from the subcommittee, and also by Franziska Marker, who is a paediatrician on the ICU at Leipzig, who's joining me as a co-chair for this session. So welcome, Franziska. Are people able to hear me? Good, okay. So the format of the session will be, I'll give a brief introduction just on the newborn life support guidelines and the process that we undertook to produce these. And then we're going to run through some of the core elements of the guidelines. And for that, I'm joined by my co-presenters for this. That's Charles Raw, Mario Rudiger, Thomas Sapper, and Jonathan Wiley, who'll be talking in detail about some of the other sessions. And then at the end of the session, the plan would be that we stop at that point, and then we've got time for questions. So we'll hold the questions to the end of the session, if possible, but people can post the questions during the session and we'll be collating those. So without any further delay, I'm going to run through these guidelines as an introduction. So next slide, please. There were 13 of us who worked on the guidelines on behalf of the ERC from around Europe. A lot of effort went in over some months, and so the guidelines are a culmination of a lot of hard work by a lot of people, and I hope that they prove to be fruitful. Next slide. So we're all involved in other aspects of newborn life support and resuscitation, but none of us felt that these were conflicts of interest which would have prejudiced our ability to produce these guidelines. Next slide. So the guidelines, as previously, build on the works of others. We stand on the shoulders of giants. And in this case, the 2015 guidelines were the basis for the current 2021 guidelines. And we change where change is recommended on the basis of the evidence, and where there was no change recommended, the guidelines stay very much the same. So these are built on the basis of the ILCOR co-stars and evidence reviews, scoping reviews, evidence updates, and where necessary work that we undertook to review the evidence ourselves. Next slide. So these are the guidelines that you can now see on the ERC website, and which would be published and are in publication at the present time. Next slide. So the format of the guidelines, there is a summary of the changes which illustrate the key points which have changed from the previous guidelines. There's an innovation this time, which is the infographic, which you'll have seen for the other guidelines, following a standard format, which is a pictorial representation of the key points. And these could be used for either clinical practice or education. There's a revised algorithm, and then the guideline itself has a new format with a concise guideline for clinical practice, and then evidence informing the guidelines as a separate section. Next slide. So the infographic follows the now familiar format of 5 key points, with an individual sheet on each of the 5 key points, which runs through some of the key elements which are in the guideline. Next slide. And the algorithm has a familiar feel. It has the same linear approach that we've adopted previously, with advisory elements to each side. There are new elements which you'll see as we work through the talks today. Next slide. So what I'd like to do is just briefly run through the algorithm. This is the video presentation that you may have seen, but I'll do this for the benefit of those who may not have seen the video presentation. So next slide, please. And next slide. So initial steps are unchanged, with antenatal counselling, team briefing and equipment check, largely because we can, on some occasions, predict the need for resuscitation and or stabilisation. So therefore we can prepare in advance, and it's good clinical practice to do so. Next slide. At birth, we now have introduced cord clamping as a formal element of the process to consider this, recognising the benefits, and we'll talk about that shortly. Next slide. An assessment is essentially unchanged. We wish to undertake good thermal care as a priority, recognising that this affects outcome. For the first time on the algorithm to the left, there is a box advising for the preterm baby. So now for the less than 32 weekers, where resources permit, we suggest plastic wrap and radiant heat. And again, on the right-hand side, there's an imperative to maintain temperature throughout the algorithm. Next slide. Assessment is tone, breathing and heart rate, which we'll hear about later. And again, at the right-hand side, an imperative to ask for help or consider needing help if required. Next slide. Ensuring the airway is open is a priority, and for the first time for the preterm baby, we've introduced the consideration for CPAP, where a baby might need respiratory support if they're breathing. Next slide. And then essentially unchanged if there is inadequate breathing, 5 inflation breaths and monitoring if required. For the first time on the left-hand side in the preterm box, we're advising guidances on the amount of oxygen to be required and also altered pressures for the newborn, which we'll hear about later. Next slide. And as far as monitoring is concerned, we promote saturation monitoring and or ECG. And again, there's an advisory on the saturations required, but this has been simplified to just 3 points at 2, 5 and 10 minutes, 65, 85 and 90%. Next slide. If manoeuvres are unsuccessful, again, we retain an advisory box with actions which might be undertaken to improve the airway and breathing, including repositioning, two-person support as a superior method, suction, and for the first time, laryngeal mask and tracheal tubes as adjuncts which might be used by those who have the competencies and are able to do so if other methods are not working. And we also suggest increasing the inflation pressure where it appears that other manoeuvres are unsuccessful. Next slide. If after achieving airway and breathing, matters do not improve and the heart rate remains very slow or absent, recommendations are unchanged to commence cardiac pressures after 30 seconds of ventilation with 3-to-1 ratio and an increase in the oxygen. At this point, we now suggest consideration for intubation, if not done already, or a laryngeal mask to secure the airway where a resuscitation is prolonged, recognizing the importance of a secure airway in this situation. Next slide. And if matters require venous access, in addition to the UVC, we are now suggesting intraosseous be considered, as this is an alternative route that may be useful in some situations. And the drugs used are essentially unchanged, and these will be discussed later. At this point, we also now prompt for potential reversible factors such as pneumothorax or hypovolemia, or the presence of congenital abnormalities which may be confounding efforts to improve matters. Next slide, please. Now, again, in good practice, at the end of a resuscitation, we are promoting an update of the parents and the debrief of the team and completion of records. As far as outcomes are concerned, where outcomes are looking poor, we've revised the recommendations for when to stop, and these are discussed later. Next slide. So essentially, the newborn life support approach is unchanged, with delayed cord clamping, thermal care, airway support, and lung inflation and ventilation as the priorities, rarely chest compressions, and very rarely drugs. And these are the things that we'll now talk through. So thank you for that. Next slide. And at this point, I'll hand over to Charles Raw, and over to you, Francisca.
Well, thank you very much, John, for this brief introduction, and thanks to everybody involved in doing the guidelines, which was a huge undertaking. I like your image of standing on the shoulders of giants, and I'm grateful to Jonathan to bring us all together. Next slide, please. So this slide summarizes the recommendations on how to manage the infant on the cord. If you could click through, please. It's quite helpful to discuss the options for delaying cord clamping, both with the obstetric teams and, if possible, with the parents before birth. And wherever possible, we suggest to delay cord clamping for at least 60 seconds. It may be delayed longer if the infant is stable and no immediate resuscitation efforts are required. Next click. And the next click. Owing to the concept of physiological-based cord clamping, we advise that if baby is stable and cord clamping can be tailored in accordance to the baby's breathing efforts, it is advisable to wait with cord clamping until the infant has taken a few breaths. If, though, resuscitation needs to be undertaken, always be aware and mindful of good thermal care, and do make sure that the baby is stable whilst you are doing cord clamping. Next one. We acknowledge that there is growing evidence for the practice of umbilical cord milking. However, owing to the current interpretation of evidence, we advise great caution towards umbilical cord milking for infants less than 28 weeks, and we would only advise it at this stage to be used for infants with a gestation of greater than 28 weeks of gestation. Next click, please. The collaboration between the European Resuscitation Council and the International Liaison Committee on Resuscitation allowed us to rely on two imperative systematic reviews and meta-analysis on the topic of umbilical cord management in the term and late preterm infant, as well as in the preterm infant. In this next two slides, I'll refer to the evidence of the delayed cord clamping in the term and near-term preterm infant. Next slide, please. As you can see in these two forest plots, which summarize the evidence from randomized controlled trials investigating a period of delayed cord clamping to immediate cord clamping for the outcomes on the left-hand side for preventing admission to a neonatal unit or special care unit, there was no palpable difference between immediate cord clamping and delayed cord clamping for term-born infants and near-term preterm infants. The same may be interpreted in the right-hand lower side, where we see the summary of evidence for effect on the infants of delayed cord clamping with regards to significant hyperbilirubinemia, jaundice, with regards to needing phototherapy. There's a signal, although no significance, towards requiring a little bit more phototherapy if you're dealing with a term-born infant who requires delayed cord clamping. And the signal is towards more phototherapy needed when cord clamping is actually protracted or immediate. Next slide, please. With regards to the effect on delayed cord clamping in the term-born infants, there is a positive effect towards a significant higher hemoglobin level in the first 24 hours of birth, and that also reflects in a higher hematocrit in the first 24 hours of birth. So without seeing a clinically significant difference in terms of NICU admission, there is a palpable difference in hematocrit and hemoglobin levels between the two, favoring delayed cord clamping for term and near-term infants. Thank you. Next slide. The same group has done a meta-analysis and systematic review for preterm infants of less than 34 weeks of gestation. Next slide, please. Taken together, the effect on delaying cord clamping in preterm infants is such that it summarizes a improved survival in preterm infants, survival to discharge in hospital. Without going into detail, this effect seems greater in low and middle income countries than in high income countries. However, the summary of effects is greatest for the preterm infants. So delaying cord clamping saves lives. Next slide, please. Next slide, please. When it comes to discussing umbilical cord milking, as you can see from this forest plot where all the summary diamonds cross the line of indifference, the verdict on umbilical cord milking is still out for preterm infants. Next slide, please. There may be a signal towards increased survival for intermittent cord milking versus delayed cord clamping if cord clamping is just about 60 seconds. Next slide, please. Next slide, please. When, though, umbilical cord milking was compared with delayed cord clamping of greater than 60 seconds, the signal was lost. Next slide, please. Next slide, please. So this is the reason we caution against, and this is also illustrated in this recent meta-analysis, against umbilical cord milking for the less than 28 weeks gestation infants. Jasani et al. Published in March this year, published a network meta-analysis where by graphical illustration of the magnitude and number of infants included in studies and the interconnecting relation marked as the width of the bars between those round circles in the graphic denotes the number of studies investigating the effect of different interventions. Next slide, please. There was a signal towards equivalence between umbilical cord milking and delayed cord clamping. However, as you can see, the 95 confidence intervals cross the line of indifference, thus being an inconclusive result. Next slide, please. This brings me to the summary. The systematic review and network analysis by Jasani et al. Shows that the delayed cord clamping group compared to other forms of cord interventions have the latest mortality, and infants receiving delayed cord clamping or umbilical cord milking on the whole do not seem to have higher rates of intraventricular hemorrhages, which is an upside considering either of these interventions. Thank you. With regards to terminal care, next slide, please. Here's the summary of the slide, and as John has explained, we found no new data leading us to change the guidance. Next click, please. It is highlighted in the infographics that we, owing to the fact that temperature loss is a great risk factor for adverse outcome, urge all teams who attend newborn deliveries to be very diligent with terminal care and avoid heatless at all cost. For the term and late preterm infants, this means immediate drying, disposing of the wet towel and wrapping the term and near-term infants into a dry and warm towel. And for preterm infants of less than 32 weeks of gestation, to place in the infant wet and undried into a plastic bag or wrap in plastic foil, saving the face and mouth and nose, and put under a radiant heater. It is important to recognize that infants respond very well to stimulation by touch and also talking to, and it is important to stimulate babies throughout the process to enhance their transition. Thank you. Next slide. The network meta-analysis about to be published compared the different combinations of thermal interventions that can be applied at birth. Next click, please. A number of interventions are possible, starting with wrapping the baby in dry towels, putting on a mitten, putting baby in plastic wrap, using exogenic heat mattresses, or putting baby under radiant heaters. As you can see by the dotted red line of indifference compared to standard routine care, each and every one of these interventions seems to, on the whole and in the mean, be more effective than just routine care. However, plastic wrap or bag has the smallest confidence intervals, and the mean is snugly away from the line of indifference. If you look at the graphical representation with the dots and the interconnecting bars, you can also see that this intervention has been most studied of all, and remains the most significant and not tightly knit evidence for keeping baby's temperature stable. So use of a plastic bag or wrap in the context of dealing with a preterm infants of less than 32 weeks of gestation is definitely advised. Thank you.
Thank you very much, Charles, for this very nice and scientific approach on how delayed cord clamping and thermal care is of such a huge importance. And thanks, John, also for this nice and crisp intro in the beginning. I would like to hand over to our third speaker, Mario Rüdiger, who is the head of the Neonatology and Pediatric Intensive Care Department in the Clinic for Pediatrics in the University Hospital Dresden in Germany. He will now introduce us to the topic of assessment and monitoring of the newborn. Please, Mario.
Okay, Franziska, thank you very much for the introduction. John, Charles, very nice work. And I have to agree, it was a very, very impressive time we spent together for the last few years to write these guidelines. And so it's impressive to see how much science is available, but also to see how little science is available on some aspects. And so it was our task not only to put the science into the guideline, but also to adhere to different approaches throughout Europe. And that was very challenging. And I want to summarize some aspects concerning assessment and monitoring. Next slide, please. So if we talk about assessment, that's a very old topic. It started with Virginia Apka, but we said it's very important, still very important to have on one side a rapid assessment, and we have to have a frequent reassessment. And the next slide shows that rapid assessment is important to establish baseline, to identify the need for support or resuscitation. And that's very important to differentiate whether the baby needs just some support or has to be resuscitated. And finally, it's also important to decide whether we can go ahead with delaying umbilical cord clamping as just presented by Charles. And frequent reassessment in the next slide is shown that it's important for to decide whether there is an adequate transitioning or whether our interventions are appropriate or some further interventions are needed. So we can kind of escalate the interventions in this approach. Next slide, please. Concerning the parameters to assess, we decided that tone and color are important. Next, and tone is important to check whether the muscle tone is appropriate for gestational age. So we decided not just to have a lower tone or so, but it should be appropriate for gestational age in order to differentiate between very preterm babies and term babies. And we acknowledge that floppy infants are very likely to need any help. So that's a key feature, that floppy infants need some help. And finally, next one is color. And we know and we acknowledge the data showing that color per se is a poor means to estimate oxygenation, but still color is very good to check for changes and to see whether there's any improvement over time. And finally, we said a pale infant has a very high risk of blood loss, and so we should consider checking blood pressure in these babies. And on the other side, cyanosis is very normal initially, but we have to be very careful that there's no change in the cyanotic skin color, and we have to think about cardiac defects and to have to check for a saturation. Next slide is covering two other aspects, is breathing and heart rate. Concerning breathing, next slide, you have to check for rate of breathing, depth and symmetry, and the work or effort of breathing. And you have to look whether there's apnea or gasping, which indicates inadequate breathing. And finally, heart rate, we mention or we stress the point that the heart rate is a very important parameter during the process of supporting transition or resuscitation to decide whether there is an adequate ventilation. And there are several means to determine heart rate, like the stethoscope or saturation monitor, ECG, and we provided the evidence on these in more detail and the data on these in our presentation. And at least it's very important to keep in mind that an increase or stable heart rate above 100 is a very good parameter or very good indicator for oxygenation as well. Next slide. Based on these initial assessment, we kind of developed three groupings, which is one group is a satisfactory transition, which has a good tone, vigorous breathing or crying, and a heart rate which is more than 100 per minute. And so there are no further interventions needed. Next one shows that the incomplete transition can be recognized by a reduced tone, breathing inadequately, or apneic infant, or a slow heart rate below 100. And finally, the next one is showing that poor or failed transition can be found if the baby is floppy or pale, if there is no breathing or really inadequate breathing, or very slow heart rate. And based on these initial assessment, you can base your subsequent interventions on these. Next one. Second part of my talk is to present some aspects concerning the equipment and the monitoring. First of all, it's very important to have a team briefing and an equipment check. There is some data showing that this briefing has an important role in team functioning, in team dynamics, but there is no sufficient data showing that it has an impact on outcome. But nevertheless, you should focus on team briefing. And concerning equipment check, there is some specification of the equipment, but it should be adapted to the local setting and to the special environment. And there is no published evidence showing that an improvement in outcome can be achieved by specific arrangement of this equipment. Next one, please. Concerning pulse oximeter, it's a very important technique to monitor the supportive transition or resuscitation. Of course, it should be placed on the right hand. It gives information regarding heart rate and saturation, but it needs some time to get an appropriate signal. And so it can underestimate values. If the signal is poor, that should be considered if you use a pulse oximeter. Next one. The ECG is very easy and practical to determine heart rate. It's a few seconds faster than pulse oximetry. It can be used very easily in term babies, but it has some limitations in very, very preterm babies because of skin problems. And so it's especially during the first 2 minutes, it provides more reliable parameters on heart rate than the pulse oximetry. And it should be preferred if there are infants which are really requiring resuscitation. Next one. And so I thank you very much for your attention, and I think I covered all these aspects. Thank you.
Thank you very much, Mario. Okay, if the baby adapts just fine, we could probably stop here after this talk. But if the transition is somehow problematic, we need to move on to have a closer look at the airway and breathing. This is a topic Thomas Schapper is now talking about. He is an associate professor and the head of the neonatology department and neonatal biophysical monitoring and cardiopulmonary therapies research unit of the Poznan University of Medical Sciences in Poland. Please, Thomas.
Thank you very much for your kind invitation. I wanted to say that I feel privileged that I could be a part of the team updating the guidelines, and it was a great pleasure to take part in the process. And moving on to the initial airway support, we should start the life support in case of an infant that failed to establish adequate normal breathing and has a low heart rate below 100 per minute. It is important to remember that on one side, ensuring open airway aeration and ventilation of the lungs is usually all that is necessary. On the other hand, if more advanced, if for example, chest compressions are necessary or other more advanced actions are needed, and they won't be effective if we fail to aerate lungs and effectively ventilate the patient. Next one, please. In cases of such patient, we should place the neonate in a supine position. We don't want the head neither flexed or overextended, as this may affect airway patency. And in floppy infants, we should consider using the jaw lift. It may be very important. And when we ventilate such patients, the two-person methods of airway support may be superior. So this should also be considered. Oropharyngeal airways could also be considered in term infants. However, we should be extremely cautious in preterm babies, as there is evidence that it may affect airway patency, and it actually can be a cause in the preterm infants of obstruction of the airways. But on the other hand, in some cases in term infants, if there is a problem with two-handed airway support, or for example micrognathia, this can be a helpful device. Next one, please. Routine suctioning is not recommended. Actually, there are very limited situations in which suctioning is really necessary, and in some cases it could actually cause harm if it's used unnecessarily. And it's also the case in the non-vigorous infants delivered through meconium stained amniotic fluid. So in such cases, routine suctioning with or without laryngoscopy is also not recommended, as this may delay ventilation, which is the most important element in these patients. However, if the initial attempts to aerate lungs fail, then inspection and suctioning under direct vision with laryngoscopy should be considered. And the cases in which tracheal intubation and tracheal suctioning are necessary are relatively rare. Next one, please. In preterm infants that are breathing spontaneously, CPAP may be the effective method, and sometimes the only one that is necessary, and CPAP can be delivered using a face mask or nasal prongs in such patients, and for that TP's resuscitator can be a very helpful device. Next one, please. In case we have an apnoic patient or one that's gasping or not breathing effectively, then we should start positive pressure ventilation as soon as possible, and we have to take care of correct fitting of the face mask, so using the correct size and making sure that we are holding the mask in a correct manner to minimize the leak around the mask, and to make sure that we're using correct pressures. Next one, please. In an apneic patients, we are starting with 5 inflation breaths, which are given with the inspiratory time of 2 to 3 seconds. And for term infants, we should perform these inflations with initial pressure of 30 centimeters of water with air. And in the preterm infants, it should be 25 centimeters of water with fraction of inspired oxygen between 21 and 30%. And as you can see, this initial value for inflation breaths in the preterm infants has been increased by 5 centimeters of water, but we should also bear in mind that in special cases, even higher pressures may be needed to aerate lungs. And after these inflations are performed, we should assess heart rate and chest movement to assess the response to these actions. Next one, please. If there is a response, the heart rate increased and we were able to identify chest movement, however, the patient is not breathing spontaneously, then we should continue with ventilation breaths at a rate of approximately 30 per minute and shorter inspiratory times below 1 second. Those patients should be continuously monitored using pulse oximetry and ECG if possible, and we should be based on the saturation. We should be titrating the fraction of inspired oxygen. The acceptable preductal values of saturation were kind of simplified to make it easier to implement. And we should bear in mind that in preterm infants below 32 weeks of gestation, we should avoid saturations below 80% and bradycardia at the 5 minutes of age, as this was associated with poor outcome in these patients. Next one, please. If there is no increase in heart rate or chest movement, then we should check our equipment, check the position of the head, check the mask for possible leak, and we should also consider alternative maneuvers, including laryngeal mask or intubation. And we should also consider a gradual increase in the inflation pressure. If we have a respiratory function monitor available, then it can also be helpful. And afterwards, we should repeat inflations and continue to assess heart rate, chest movement, and saturation as well. Next one, please. Regarding airway adjuncts, we recommend that laryngeal mask should be considered if there are problems with establishing effective face mask ventilation, or when intubation is not possible or not available. And those were used in infants older than 34 weeks of gestation, usually around 2,000 grams, but some devices have been used successfully in infants down to 1,500 grams. Next one, please. Regarding assisted ventilation devices, whenever possible, it may be beneficial to use the TP's resuscitator, as they allow the use of CPAP and expiratory pressure with positive pressure ventilation, and they may also allow more consistent pressures and tidal volumes delivered during the resuscitation. And when we use them with positive pressure ventilation, we should consider using end expiratory pressures of 5 to 6 centimeters of water. Nasal prongs can be used as an alternative, and self-inflating bag should always be a backup in such situation. And we should also take care of using proper equipment, bags of appropriate volume. Next one, please. So in summary, regarding the topic of airway and ventilation, since the last guidelines, the points that have changed include the increased starting pressure for inflation breaths for preterm infants, and for infants born through meconium-stained liquor, recommendation against immediate laryngoscopy with or without suctioning, changing the approach regarding initial values of fraction of inspired oxygen depending on the gestational age. So for 32 weeks and above, we should start with air. Between 28 and 31 weeks, we should use the fraction between 21 and 30%, but below 28 weeks, we should start with a FiO2 of 30%. With the initial inflations, if there is no response to them, then we should consider the increase in inflation pressure. And we should also consider the use of laryngeal mask or intubation. And these laryngeal masks should be considered in infants at 34 weeks of gestation and above. Thank you very much for your kind attention.
Thank you very much, Thomas, for this nice summary of the changes since the 2015 guidelines. If despite secure airway and an efficient ventilation, the baby's transition is still not complete or is still problematic and the heart rate is still low, we will have to move on and have a look at the chest compressions, although John also already mentioned that it's not something that you likely have to be doing, but still you have to know what to be doing. So Jonathan Wiley will now give us a look at the topic of chest compressions and drugs. He is a consultant neonatologist at the James Cook University Hospitals in Middlesbrough in the UK, and president of the Resuscitation Council of the UK, and takes a great part in the beginning of NLS courses. Please, Jonathan.
Thank you very much indeed. So it's left to me to just take us through the last part of the algorithm, which affects the tiniest number of babies, but which often generates the most contention amongst practitioners. Next slide, please. So happily, nothing really has changed in the implementing chest compressions. If despite 30 seconds of effective ventilation, the heart rate remains very slow or absent, then you should start chest compressions. When you commence those chest compressions, and I'll try to deal with some of the questions that have come up, we would do synchronized chest compressions to ventilations at a rate of 3 compressions to 1 ventilation. So a number of studies have looked mainly in animals at different ratios, and they have not shown significant advantage. And in fact, in some mannequin studies have demonstrated that if you put in more compressions, then you significantly affect ventilation. We would aim for 30 cycles a minute, and the change here is that we would increase the inspired oxygen to 100%. Previously, we said consider increasing the oxygen. The evidence behind that is almost non-existent. It has to be said. However, you are not able to monitor saturation readings effectively if you're delivering compressions. So if you are successful, you still need to titrate that oxygen down afterwards. Need to get some sort of reassessment of the heart rate every 30 seconds, but continue chest compressions if the heart rate is very slow or not found. And consider intubation only if you're able, and it's not been done already, if you are delivering chest compressions, and you might consider a laryngeal mask. If the baby is intubated, we would still use synchronized chest compressions. We are not using cuffed tubes in newborn resuscitation, not as yet anyway. And the evidence suggests that if you go to continuous, you will adversely affect ventilation. And whilst we do want to get hearts started or speeded up, we know that ventilation is essential. Next slide, please. So when we think about vascular access and drugs, next slide, please, then drugs should ideally be delivered centrally, and the umbilical vein, as it has over the many years, offers rapid vascular access. However, in these guidelines, we're stipulating that intraosseous access is an alternative, although the evidence for in newborns and in neonates is actually only anecdotal. This is observational data. There has been no deep effective evidence produced in our age group. Drugs to consider: adrenaline or epinephrine at 10 to 30 micrograms per kilo IV. The intratracheal route makes a comeback if no other access is available, and you'll notice that there's a markedly increased dose. However, as you'll see, that should not interfere with ventilation, which again is paramount. Glucose may be needed in our age groups, especially with extended resuscitation. And if you give volume, we're at 10 mils per kilo blood or isotonic crystalloid. As with other age groups, we have said that we would give subsequent adrenaline every 3 to 5 minutes. It is not possible to be more specific because the evidence even for that is very poor, but it does bring things in line if you're wanting to start the heart or speed it up and nothing else is working. Next slide, please. So if the heart rate has not increased to 60 or greater after optimizing ventilation and compressions, ILCOR said, we suggest the administration of intravascular epinephrine or adrenaline, and you'll notice that that is a weak recommendation with very low certainty of evidence. Next slide, please. If intravascular access is not yet available, then the suggestion is that you can give endotracheal epinephrine if you have intubated at a larger dose than the dose used for IV administration. Again, this is a very weak recommendation with a very low certainty of evidence. And it's stipulated in the ILCOR review that that should not delay attempts to establish vascular access. Next slide, please. So the 3 to 5 minutes of adrenaline, preferably intravascularly, again, is a weak recommendation because the evidence is very low. And if the response to endotracheal adrenaline is inadequate, then the suggestion is that an intravascular dose be given as soon as vascular access is obtained, regardless of the interval after any endotracheal dose. Next slide, please. IO versus UVC. So this was a review with ILCOR, and all that could be said is that it is a potential alternative method of emergency vascular access if umbilical access is not possible, and that might be due to the situation or indeed the skill mix available. Next slide, please. So then to the next knotty issue of outcomes and when to consider stopping resuscitation. So failure to respond despite 10 to 20 minutes of intensive resuscitation is associated with a very high risk of poor outcome. So in these guidelines, stopping intensive resuscitation should be considered and discussed if there has been no response after 20 minutes and the reversible problems have been excluded. Next slide, please. So since the previous last review in 2015, there was new data from 5 observational studies, and 2 of those were population studies. So in total, 16 eligible studies were reviewed, looking at 579 newborn infants. But it has to be said that apart from the population studies, most of those studies looked at a very biased population. So some of those, of course, were in the cooling studies, and therefore, to get there, you had to have been admitted and you had to have been thought eligible for those studies. So in the end, 13 out of the 16 studies reported neurodevelopmental outcomes on 277 infants, and those are the ones I'm just going to mention to you now. Of those 277 infants, 69% died before last follow-up. 18% survived with moderate to severe neurodevelopmental impairment, and 11% were judged to have survived without moderate or severe neurodevelopmental impairment, and 2% were lost to follow-up. Remember, this is a biased population at the very least. And no specific time point could be identified which should have been a trigger for ceasing resuscitation. Therefore, next slide, please. So the decision to cease resuscitation has to remain a clinical decision, and it's important where possible to give the family updates during resuscitation and advanced warning that there is a high chance of a baby will not survive. We know that in extremely preterm infants, prolonged resuscitation is associated with lower survival rates and higher morbidity, and therefore we need to the decision needs to be individualized. However, we have said that at 20 minutes it is reasonable to consider stopping resuscitation at that time. Next slide, please. So the changes in summary are that if you're moving on to compressions, you need to consider securing the airway, an intubation if possible, or a supraglottic airway. When it comes to adrenaline, you can now give an ET dose if that can be done swiftly and not interfere with ventilation. And IO has also been highlighted as an alternative. Adrenaline should be repeated every 3 to 5 minutes if there's no response, but you must consider other reasons for response failure. And in considering the duration of resuscitation, considering stopping is reasonable after 20 minutes, depending upon the circumstances. Thank you.
Okay, thanks, Jonathan, and thank you everyone for the presentations, which I hope have given an overview as to the approach to the newborn, which requires resuscitational support. There are a few questions, and we've got a limited time, so we're going to pick some of the questions that seem to be voted as the most popular, and we'll ping them out and see where they go. And Francesca's been looking at the questions, where are we going with the questions, Francesca?
Right. Yeah, so we have 36 questions so far, and some have been answered during the talk. And the most popular one right now is, until when do you use the NLS algorithm in hospitals? Until the first week of life?
Okay, so...
sorry.
That's okay. So I'll start, but others can chip in. I think it's a moot point, and this is one that we've met before. It's a newborn algorithm for resuscitation at birth. So that sort of gives you a clue as to when it should be used. But within the setting of a midwifery unit or a place where babies are born, this is the algorithm that the staff will have been trained in. So this is the one they'll be familiar with, whereas in an emergency department or some other area, they may have a different approach because that's the way that they've been taught. So I think the priorities of airway, breathing and circulation in that order are the priorities irrespective of the algorithm, but the basic principles are the same. So I would say at birth. I don't know what others feel.
Great. Oh, Mario.
No, just one comment. If you look at the pediatric recommendation, it says it's for 0 to 18 years of age, and it excludes the birth situation. So I think, as John just said, it's at birth. Yeah.
So I just say that we take a pragmatic view and we use this approach on the neonatal unit and on the postnatal ward, unless we know that there's a cardiac cause, in which case that would change things and we would have babies monitored. But that is a pragmatic approach so that everybody uses the same approach. If you are a newborn baby and you come in through the emergency department, you'll get a pediatric approach.
And it may be worth just reiterating what Jonathan said. The evidence for or against one or the other is marginal and doesn't really stem from much human data. And I think Jonathan's pragmatic approach stems on the background that you, as a team, you train up to do one thing well, and you try to act on your best potential and activity as a team.
I think this feeds back into something else, which is another question that was in the group, which was about 3:1 versus pediatric ratios for cardiac compressions. And it's the same thing. Within the midwifery department and within the maternity department, our staff are trained to use the neonatal approach, so they'll go 3:1. But if they come in through the emergency department, the staff there are going to give you a different ratio because they're using the pediatric approach. And it's a pragmatic one. And again, I think it reflects something else, which is that a lot of this is based upon limited evidence and just a consensus on approach.
Okay, thank you very much. I will head on to the second question with a lot of likes. This would be directed to Charles. So during delayed cord clamping, during a C-section, the baby is exposed to the theater temperature air during this minute. Should we dry wrap before clamping?
Yeah, it's a very good question. Thank you very much. And clearly the ins and outs of how to best perform delayed cord clamping in situations like in theater, in a cesarean section, in a sterile environment are still being refined by different teams. Clearly, the first and foremost thing is to have a good relationship with the obstetricians. To, if they are willing to do delayed cord clamping for you, they may be willing to increase the temperature of the theater to at least 25 degrees, which is one but not the only sufficient thing to do to prevent heat loss. So yes, you're right. If the team is by the bedside, if a midwife or a pediatrician is scrubbed up to catch the baby in a bag, that would be the best thing to do to avoid evaporative heat loss, convective heat loss, etc. The drying probably relates to the more term-born infant. So I would like to summarize my answer just saying, do whatever you can to avoid the baby getting cold.
Thank you very much, Charles. Yeah, we've only 5 minutes left, so I think we might have time for 2 more questions probably. The next most popular one would be, about the pediatric guideline is then advising to provide continuous compressions. What would the NLS guideline recommend in that setting? And another one referring kind of to that as well is on how the baby should be ventilated once it's intubated, if the chest compressions should be continuously. That one probably goes to Jonathan.
So yeah, I hope that I'd picked that up, and I'm sorry if I wasn't clear. Still, at the moment, the advice both from actually ourselves, ILCOR, and the NRP would be, even with a tube in, you synchronize compressions to ventilation, and that's because of no evidence as yet that another approach improves things, and some evidence that you can adversely affect ventilation. We do know from asphyxial animal models that whatever you do in terms of compressions and drugs, if you are not ventilating properly, the baby dies, or indeed a piglet, or indeed a rabbit. So at the moment, the safe approach is felt to be to maintain, as we use an uncuffed tube, synchronized ventilations. I would say, perhaps just picking up another question about whether we have evidence for different rhythms at birth. Of course, we've only relatively recently started using ECG, so we're only really learning about what sort of rhythms there are at birth. And it may well be that in certain situations, a cuffed tube and a continuous compressions might be a better outcome, but to do that at the moment would be offering a possible unknown advantage to a tiny number of babies and offering a major detriment to the majority of the babies that we're dealing with. And so now is not the time to change to that approach.
Thank you. Maybe we'll just hit on one last question. That would be, should we use a higher PEEP in preterm infants? I would direct that to Thomas, please.
Okay, thank you very much. We're in the guidelines, we are regarding the PEEP values, we are mainly indicating this for preterm infants. Of course, if there is a term baby requiring positive pressure ventilation, then and expiratory pressure can also be beneficial. So, but so my short answer would be that the same values would apply for term and preterm. With regard to the end expiratory pressure, if it is a term baby breathing spontaneously, then we should be very careful with CPAP as complications may be associated with the use of CPAP in the term babies. But as far as the values of end expiratory pressure during PPV are considered, we recommend same values for term and preterm.
Okay, thanks a lot, Thomas. As for myself, I would like to thank the opportunity to co-moderate this session here with you. And I would give the word back to John, I guess, and like to squeeze in that it would be great if you would give us a hashtag take-home message. Thank you very much.
Thank you. I'm not greatly into hashtags, so I'm going to leave hashtags to somebody else. I'd just like to thank those who've contributed to this session for their input, not just today, but over the last few months in terms of helping to make these guidelines what they are. I hope they prove to be useful and helpful for those who need them. And for those who've attended the session, I'd just like to say thank you for attending the session. I hope you found it useful. We found the questions stimulating and provocative in some cases, as ever, and some of the discussions offline have been equally provocative, I have to say. So from me, it's farewell, and I hope you enjoy the rest of the sessions today and enjoyed the sessions yesterday, and I'll leave it to the panel to say anything they wish to say. Thank you.
Just say goodbye and thank you for taking part, and thank you for all the questions in the Slido.
Thank you. Thank you, everybody.
Thank you very much.
Thank you. Bye-bye. Enjoy your stay.